wabarakatuh. I would just like to present a very short comprehensive guide for adapting AI in a radiology department. So what are the challenges we face when we want to adapt AI in the radiology department? There are many challenges, including challenges with the radiologists themselves, because they will question the accuracy of the AI, they need training for the AI model, and of course, how AI affect their workflow. And we have challenges with the IT department, which include the cybersecurity, integration into the existing system, and of course, the IT infrastructure. High management, when we discuss implementation of AI, so we go to the other part, which is the return of the investment, how to maintain your AI, and how to monitor your AI solution. So first, we have to identify our stakeholder in radiology department. So our stakeholder, including patients first. So what the patient looking for in AI, they are looking for a fast result, early booking for their study, and the AI to enhance the precision medicine. What radiologists and technologists looking for in the AI, they're looking for enhanced efficiency, reduce time for reporting, as well as allocate more time for the complex cases. Referring physician and an institution, they want to improve a TAT, which is turnaround time. They improve ER and inpatient workflow, and maybe the AI will have additional revenue to the institution. So it's very important to know that the clinical application of AI in radiology, though the interpretive part is very popular, even in the social media, there are another part which is non-interpretive part of AI in radiology. AI in radiology, it starts actually from the when the patient journey starts in the department. So after we receive a request form from the physician for any radiology request, the AI module start to have a role with scheduling, prioritization, doing the scan in CT, like decreasing the dose or MRI image quality. It play a role in triaging and filtration and prioritization of the study. And maybe there are some AI also give recommendation for the follow-up scan and automatic scheduling for the next scan as well. Interpretive part, this is the commonest part, everybody talking about interpretive AI, and AI actually it's identify the abnormality with CAT-T, which is most common FDA approved AI solution. Actually, they are only for triaging, so they will just flag the study. The second common is detection, so it only mark the abnormality, CAD-E, and CAD-X, which actually give you the diagnosis. There are very limited number of FDA-approved AI solution, and it give you the diagnosis and classify the abnormality. By July 2025, we have 1,247 FDA-approved AI solution. 77% of these solutions, which is 956, are in radiology. So in radiology, as an AI champion in the department, you have to determine the need of your department. You have to filtrate all the AI products in the market, and you have to evaluate these AI product in short-term pilot study before applying the AI product in your institution. So there are, as I mentioned, 900 plus solutions in the market. All these solutions, when you want to apply it, you have to go into data privacy, cybersecurity, IT hosting, integration, how you are going to build the company, and the testing and pilot study. And there is a single solution for all this, which is AI platform. So AI platform is the future of the radiology, where you have an orchestrator. It has all the application you need. And with AI platform, actually, it's actually recommended by the ACR in 2024. And they consider it as the future of the radiology. And this is a very interesting article, actually. I found it in American Journal of Radiology. And they study the return of investment in using AI platform in the radiology department. And they found that in 1 year, the return of the investment, and we saw earlier how much the return of the investment in humane. And actually, in this study, they show that the return of the investment is 451%. From the regular investment in 5 years. And if you go through the study, it's very nice because they actually study the return of the investment, not actually in actual money back, but how can AI decrease the timing for reporting? How can you increase the number of scheduling using AI because of the fast reporting time? And how can you facilitate the patient in the ICU and the ER, the timing, the TAT, how can you increase it. And they have this, they call it ROI calculator. So AI platform, the challenges we had before, AI platform may solve these challenges. It will enhance the workflow for radiologists. The radiologists will have training on the AI from the same company. The IT department, they will have a single integration into their system instead of multiple integration. However, still cybersecurity is an issue. And the high management, they will avoid the cost for multiple AI vendor, and they will have more efficiency in the system. So for AI choose wisely, we have to shift from the AI hype into the more clinically applicant and clinically relevant AI solution. Though AI radiology platform is the future of radiology, not all the hospital can use it. Still, the AI integration, it's an issue, and also the cybersecurity is a big issue for the AI platform. So AI integration in the radiology department should be human-centered, not replace the irreplaceable radiologist. Thank you. So I would like to welcome to the stage Dr. Abdulaziz Almosabihi, Dr. Metab, and Dr. Abdulrhman. So our panelists are Dr. Metab Alkubeyyer. Dr. Metab is working as a consultant radiologist in body MRI at King Saud University since 2011. Also, he is a part-timer consultant at advisory in SDAIA since 2021. He is a co-founder member of the Society of Artificial Intelligence in Healthcare in Saudi Arabia in 2022. He practice and teach radiology and supervise research in artificial intelligence application for resident, fellow, and computer science master students. Dr. Abdulaziz Almosabihi, he is a board-certified general radiologist and neuroradiologist. He has served as a radiology and neuroradiologist from 2007. Currently, he held a position in General Director of Radiology and Applied Services at the Ministry of Health since January 2020. Dr. Almosabihi plays a key role in MOH Virtual Hospital by leading their teleradiology service. Dr. Abdulrhman Aljouie, Dr. Abdulrhman, he is Assistant Professor of Computer in King Saud University for Health Alliance and Chairman of Data Management at King Abdullah International Medical Research Center. He specialized in artificial intelligence application in healthcare. He published several peer-reviewed research articles on cancer risk prediction and infectious diseases, with focus leveraging medical imaging and genomic data and AI in advanced diagnosis and prognosis. Welcome all. So we'll start with my first question, Dr. Abdulaziz. How is AI currently transforming radiology from your experience, and what tangible benefits are being observed in clinical practice?
Yes, thank you, and thank you for the organizing committee and for the attendees. I will answer it from the administrative and leader perspective, then I leave the second half for Dr. Metab. With a short dialogue which happened last week with our leaders. He is the Assistant Minister for Health Services. He's usually doing the quarterly visit for our teleradiology office in Sahha Virtual Hospital. And that day, he has been in the radiology office. He was observing the radiologists doing their reporting in the workstations, and we show him some of the AI applications. He turned around to the radiologist and asked him the questions, where did you see yourself in the near futures? It's not the question of the interview where he's saying, where do you see after 5 years? But it's saying that to explore how did they behave in the futures. And he answered to them in a 3 statement that continuing the same work that you are doing today will not be the futures. You cannot perform the way that you are doing currently. Second questions, you have to adapt and introduce and use the AI in your usual practice forever. The third was mostly even as a leadership, we will not depend on radiology in the AI, artificial intelligence per se alone. So all of these combinations has to come together, augment the way that you're working. So it's almost a leadership paving the way how is AI to be integrated with the radiology services. And this is, I think, the transformation which will happen in the radiology services in the futures.
Dr. Metab?
This is a very interesting question. I remember in the old days where we have our plain films, and we were very excited to have a PAC system and VNA system. And they keep telling us it will enhance the workflow. But back then, when I was resident, I used to, whenever I didn't finish my work, I take the plain films, I go home, I use my light box to write my report at my room, then go back to the hospital. But the more advancement we get, there is also sometimes more hurdles, as we're gonna see for that. So we're gonna lose some of the flexibility, but we're gonna add other privileges in AI era, meaning we used to, let's say, I see a textbook in 1920, a radiologist used to dictate 5 cases a day. With the PACS era, it's jumped into 30 to 50. With AI era, probably we're gonna reach much more than 100. And I don't know if it's a good thing or not.
Thank you. So, Dr. Abdulrhman, what roles do research partnership between radiologists, data scientists, and researchers play in refining AI applications?
السلام عليكم جميعا صبحكم الله بالخير and it's very nice and good morning everyone and it's very nice to be amongst you and happy today to see the crowd very interested in research. And before answering your question, and I want just to highlight that radiology is one of the areas that or early adapters of AI application, and in fact 77% of FDA cleared and approved medical devices or software as a medical device is in radiology. So having seen, saying that, research plays an integral part of this, and as the question you mentioned, the 3 stakeholders, let's say, the radiologist, the data scientist, and researcher. We need the 3 in order to come up with a brilliant solution that will be put in use. Otherwise, it will be in the research lab and in the drawer archived. The collaboration should be the ideas coming from the pain, where the radiologists see and to accelerate the work within radiology. So the deep understanding of the problem comes, or the idea of what to solve comes from the radiologist after sitting with the data scientists, who are the architects that will build or fine-tune in nowadays the large language models. So building from scratch is a habit from the past, I would say. It's always now to pick up a very good foundation model and build on it, whether it's a general foundation model like Queen 3 nowadays, or 5.4 from Microsoft. These are open models that you can build upon, and then the idea will be discussed with the data scientists, and the research scientists also needs to be involved. So to make sure that the design of the study is well put, and as well how to put the safeguards for ethical approvals and so on, so to make an ethical AI and explainable AI at the end. So these are the stakeholders that I see needs to sit together in early stages to design the study, to see whether it's feasible or not, because some of the ideas are infeasible or cannot be done using the technology. That will come from the data scientists as well as the research scientists. And the ideas, as I mentioned, comes from the radiologist, and it's an interdisciplinary situation that needs to happen in order to come up with a brilliant solution, in my opinion.
Thank you, Dr. Abdulrhman. Dr. Metab, I know you for a long time now, and you are our champion in health informatics. And Dr. Metab, actually, he did a fellowship in health informatics as well. So what feature of the future PACS risk system should be included in to ease the consumption of AI model?
Yeah, we were glad that Dr. Amna showed us some of the slide. In radiology department, we basically deal with three types of data: administrative data, clinical data, which are both textual data, and lastly, medical images. So you could think that we're gonna deal with multiple standards for imaging, the DICOM standard, for the clinical, the HL7 standard. For administrative, it might be HL7 or other things. So if I'm going to invest in having a pack system, I have to be aware of all those three categories. Now, one of the most important things nowadays, a lot of vendors, they will sell you a monolithic system where you have an image viewer, a reporting modules, a scheduler, a billing. So we could have them all in one system, or we could fragment them in separate system, and they are integrated with another standard. And I put very emphasizing on the new standard that each days are coming. Many of the AI nowadays, they promote something called MPC or model context protocol, and it's gonna ease the work for you in aggregating data, sending data, filtering data. So if you want to adopt that MCP, it's very important to have a RESTful API product. And unfortunately, many of those markets still, they don't adapt RESTful API, except on the research component, which they are adopted. So one thing, make sure that your system is RESTful API compatible, whether it's a FHIR or non-FHIR HL7. And for the DICOM aspect, we have two kinds of standards in DICOM. We have the DIMC old protocol that we connect with our machines, the CT, the MR, the X-rays, and the newer standard, which is called DICOM Web, which is in between brackets a RESTful API DICOM standard. So again, RESTful DICOM and RESTful HL7 or non-HL7. So I need to make sure to have those in my system, because that allow me two things: importing data and exporting data. Many systems can import and ingest, but you cannot export things unless you call the company and you pay extra money for that.
Thank you, Dr. Metab. Dr. Abdulaziz, can you share with us any case study from your experience or AI model developed within the Sahha Hospital or MOH?
Yes, thank you for these questions. Actually, when we start thinking of the AI, and probably you hear that all they're saying, choose the one which is having a pain, so you could manage them. But actually, and this is one of the beauty of Sahha Virtual Hospital, that we kept it as open for everything. So we work in three paradigms when we speak about the AI. The first was the pain, where we'll have an issue, so we could use the AI, and that was an AI for chest in Al-Hajj, which I'll speak about it. The other one was with almost a mature, you have already mature, well-proven an AI in the market. That was the stroke, and probably most of the radiology, they know that the AI in stroke is almost a powerful one, and we are working on it, and we have one also, and we purchased it already. The third one was an experimental, where we didn't yet publish it. We are working on it with a different company, and the initiation was actually from, not surprisingly, but it came from the medication company, where they want their product to be there. So it's linked to early detections of certain disease. Well, that was spondylolisthetic ankylosing spondylitis, where we'll try to see is the MRI of benefit for the early detection, so they could initiate and start their medications. We didn't yet finalize the report, but we have a successful story for that one. We managed to get 100 cases from different countries, and we will work in finding and finalizing the result for that one. For Hajj, which is probably the one which is, I'll say, is predominant for us and of pain, where we manage actually to use the AI in triaging the cases for chest X-ray. We implemented in 2023, and that was on the level of the radiology department. We didn't go beyond that for the physicians. We tested, we find how it's helpful and beneficial for our radiologist. We did almost 600 cases. There was not much discordant between the result of the AI and our radiologist, although we didn't get a good adoptions from the radiologist to work with the AI and comply with their result. They depend more on their judgment, seeing just only the result, but it was not having that much impact, which is usual and accepted as initial phases. The next year, which is 2024, we expand more and we allow the result for chest X-ray to be seen by the physicians, in particular in the emergency, with just only an overlay. They didn't see a report, so there is no a report, so it will not be go to a medical legal part. So there is no report, it's just only overlay of the finding on the images, which actually we find it almost beneficial, which trigger actually a questions between the physicians and the radiologists to explore more of the findings. We get a good feedback from the physicians that they were a stage that might missed some of the cases, but the alert for them allowed them to go and communicate with the radiologist and get the good feedback from them. For the AI, which we already purchased, which is the AI for the stroke, we are having a good result, good adoptions from the radiologists because they are seeing a good result. It helped them in two parts when they measure the aspect score and measuring the midline shift in numbers. You know, most of the radiologists, they were not keen on writing the aspect score, how much, but some they are keen on that one. And even when they are describing the midline shift, they describing it as a statement without putting the measurement. So these two tools help them to adopt and work with the AI. So these are the things which we think make it more beneficial for them.
Thank you. Dr. Abdulrhman, do you have any experience from the research part?
Sure, and thank you for this question. Sometimes you talk the talk, you want to walk the walk, like you want to see some of the collaboration that resulted in a system that is implemented or used in the healthcare system. And I really like this question because I want to shed light into two collaborations that we've worked on. The first one, an internal, totally in-house and with no funding. And the other one is an international collaboration that I'm involved in with Brunner Lab at Harvard. And the first one, which I hold dear to my heart, is when I came back from the PhD, it was at COVID that time. So I've reached out to infectious disease department as well as the radiology department. Dr. Sha'lan is a colleague of yours, was the chairman at the time. And I came up with an idea that they need, in fact, which is the mechanical ventilation prediction as well as the mortality of COVID-19. And thankfully, Dr. Mohammed Al-Awad was coming to KMARC before I come, and so the GPU was there. We had the GPU at that time, V100, so we utilized it to build a multimodal application using AI, where we took as an input the chest X-rays of the COVID-19 at the diagnosis, and all from routinely collected data, as well the CBC, which is the counts of the blood, which is a test also collected, which shows the white blood cell and so on, which is very important, as I understand, from the infectious disease department. They say that it could be a hallmark to decide mortality and mechanical ventilation, as well the demographics and age and gender. We all know that it's a big factor in deciding the prognosis of the disease. So we built the model, and when it was published, and we got an accuracy of 81, balanced accuracy of 81 for mechanical ventilation, as well as 80% on mortality prediction down the road. And the second case study, which I want to highlight, it's related to where we're sitting today. It's related to education. So it's called Rad Game, and it is in collaboration with Brunner Lab at Harvard. And what we build is also not building a model from scratch, but rather we use APIs to connect to Midgema, which was released just recently from Google. It's a very good model that I encourage everyone to look into. And we connect with it, we build an application, an interface to it, where we localize where the findings are, and then we give feedback to the radiologist. This is one group. The other group, they study in a traditional way. And those who studied using the feedback of the AI were faster to solve the problems, 1.8x. And in terms of accuracy, it was 70% increase from the traditional learners. And this is a big, it's a big thing that I think will shift how we educate medical students and how the delivery of radiology education will be in the future.
Very interesting. Thank you. So, Dr. Metab, going back to you, between cloud solution and on-premises solution, which should I choose for a scalable AI adaptation as a radiologist in radiology department?
Yeah, that would be depending on the size of the hospital. Are we dealing with small clinic, polyclinic, secondary hospital, tertiary hospitals? So each one has its proper architecture to adopt cloud solutions versus on-premise solutions. But if my department, let's say, have some data scientists or IT people, definitely I would go with on-prem, because I would have much more control to design my workflow. And even we know that whenever I adopt a vendor from AI models, eventually those models might be drifting, meaning sometimes I'm going to change my machines from one vendor to another vendor, and that model was trained into a specific vendor. And instead of relying on cloud services that has been trained on multiple centers, I might have a better result if I train it with my local one. So it would be very interesting to control it if it's within on-prem. The second thing is in-prem, also what we hear a terminology called edge-based solutions, where you have a middleware or a middle device that's going to be attached to your machine that doesn't need internet connections. So if I'm, let's say, working in Hajj, and I need a portable machines that gonna take an image of the patient and make a quick diagnostic, and it's gonna be sent to the radiologist. So edge solutions might be the proper way for small portable devices that you don't need to connect to the internet because of the security issues and the privacy issues. So one last component many people are adapting is what they call the hybrid solutions. And remember the slide that we saw with Dr. Amna, am I dealing with images or textual data or administrative? So for me, if I'm going to deal with administrative data for scheduling, I don't mind to be on the cloud. So nothing very sensitive, reminders, taking scheduling. But if there are some sensitive informations, cancer patients or not, having it on-prem might be a proper way.
Thank you. Dr. Abdulrhman, how is, we heard this morning that a genetic AI actually is just an application with a fancy name. So what do you think the role of this fancy application in radiology?
Sure. I would say it will transform how medical or how healthcare will go in the future, and it's a serious application that is more of an engineering. Yeah, there is no AI within the agentic itself. However, it will move us from a reactive, pessimistic models into a proactive, the models that will take a decision on behalf of us and then act on it. And how many of reminders that you receive you didn't act on? Myself, it counts on the hundreds weekly. So the agentic AI will take the decision if you give it the approval, which is a software on top of an AI model that will take a decision and then act on this decision. Meaning, like if a diagnosis that has been seen or an observation in the X-ray, it will send a text message to the radiologist, and also to start, for example, the appointment booking for the patients, and will do a lot of autonomous activities for the radiology in specific, and will transform, in my opinion, how radiology department will operate in the future, whether from administrative, as Dr. Metab just mentioned, or from medical as well, in terms of taking a decision and then pinging the radiologist for the action or taking the action itself. Who knows, maybe with robotics also connected to the agentic AI, we will see, for example, endotracheal positioning, which is a problem, will do it automatically without the interview of humans. That's what I'm imagining the future to be.
Sure, thank you. So one closing thoughts for all the panelists. Dr. Abdulaziz, if there is one thing that radiology community must do now to get AI right, it is? What do you think?
Immediately implemented.
And Dr. Metab?
Yeah, make sure that your system adopt RESTful APIs to utilize most of the AIs.
And Dr. Abdulrhman?
Share data after the identification.
Okay. And for me, Dr. Abdulrhman asked me to answer this question as well. I think we have to start by training the radiologist, because what I see in real life and in the with radiologists, there is some resistance from the radiologist, and the resistance actually not because they think AI will replace radiologists, but because of lack of knowledge of AI. So I think we have to start a real training, and to have training, including from the residency training program.
Absolutely.
Thank you. So I would like to thank the panelists, and if there is any question.
We have any question?
Assalamu alaikum. Thank you for all the panelists for this interesting, informative session. My question for Dr. Abdulaziz, I'm just elaborating, echoing a point that you were discussing, implementing a model that was helping clinicians when there was some issues already that was happening in the background with regarding like documentation or recording a score. So I'm just trying to elaborate on also what Dr. Amna was saying, like training clinicians, and because I'm particularly interested in the human side of the AI. So do you see it as, you know, when we implement that and help support the clinicians, is it a way of making them skip that best practice that they're supposed to be doing already? When we're making things easier or efficient, which is, of course, that's the aim, or is it a way to empower them to focus on what's important, because we don't want them also to forget what's necessary and the background knowledge of what they're implementing. Thank you.
And thank you for this. Although my perception is opposite to you, is that actually we are seeing in the practice most of the, or let's say most, some of the radiologists, they are skipping this part of documenting certain measurement, which is an important for the physicians to follow. And they have to go back to the images to see this measurement. But if it is included in the report, you will make the life and the decisions of the physician more easier. Even at the level of which we thought that we might ask these to be a part of the mandatory reporting, that certain cases, this measurement has to be within the report. And to give you an example, some of the masses, they are not, I'll say some of the radiologists, they are not giving the details about the size. So they must give you just only 2 diagonal, and they're not giving you the exact volume, which will help in the futures for these cases. They have to go and see these images. This is why I'm saying the AI really will help the radiologist and emphasize on these parameters once it is ready there, available easy to see and easy to track. Thank you.
Thank you. Do we have any more questions? Oh, sure.
Assalamu alaikum. Thanks all to the panelists. I'm Amr Hati, a pediatric radiologist at King Faisal. It's a comment and a question to Dr. Abdulaziz. My comment first, as a radiologist, it's very exciting to see the advancement in AI when it comes to image recognition and pathology recognition. But in my opinion, what is more important for us is what makes us more efficient and faster. And that translates into not only pattern recognition or pathology recognition, because it's not what is taking most of our time. In my opinion, what is taking most of our time is checking priors, comparing sizes. For example, if an oncology patient, if a patient coming in with 7, 8 scans, it takes a lot of time to go over these scans and compare them and then come up with the final conclusion and so on. So I think, I believe there would be more beneficial if more focus on these aspects to be implemented in the radiology world that will transform the practice in the future. My question is about the stroke model that was implemented. How soon are we going to see it in MOH hospitals across the country? And if there are any other models for other entities such as PE or bowel obstruction or bowel ischemia that will be coming soon? Thank you.
Yes, thank you for this question also. We have now a tele-stroke programs across the nations, and part of it mostly is covering the MOH hospitals. So part of our experience that we had in Sahha virtual hospitals for the AI in stroke, we will try to implement it in the tele-stroke project, which also actually is transferring these knowledges to those sites who are linked to the tele-stroke programs. Although the tele-stroke is now more predominantly covering, let's say, the smaller hospitals where they don't have the expert, but once we implement it there, we can expand it more. I know some are using the what they called as a rapid AI, which facilitate some of the work, and it's mostly used by the neurologist rather than the radiologist. But we could share the experience between the two and making a good value from the experience of both. Regarding the prioritizations, most of the AI, and even the AI that we have and you are working, it's actually prioritizing the cases in the top where there is an AI finding or positive finding. It come up in the list as the first one, and it's ranked. Those positive are up, those are negative by the AI are below. It doesn't mean that the AI is true in all the way.
May I comment on Dr. Omar comment about the AI in radiology? I think we are still at the level of narrow AI in radiology. This is first. Second, it's very difficult to train the data by supervised learning and labeling the image. That's why most of the FDA approved solution are actually triaging. So it's easier for them to have this model than developing a model while you have this certain diagnosis. But there are models now, like for the MS, for example, they can detect the lesions from the previous scan, and it give you the new or the disappearing lesion in the follow-up scan. So there are some new solutions, and they are working with the same tract as you mentioned, but still the CAT-T, which is triaging and prioritization, is more because I think it's easier to have the data label on that study than the diagnostic one.
Dr. Metab, can you add?
Yeah, for those who are excited to test things in the water, all the major radiology applications, we could use them for free, but not as a clinic, as a research product. And I would emphasize in that. So if you want to tackle those things, you could find for the stroke, for lung nodules, for PEs, for fractures, for bone age. Multiple of those solutions are online, and they have been trained on multiple public data sets all over the world. So if I were you, I could download that model, and I adopt it in my practice, and trying to make the drift into my population step by step within a year. I know saying it is very easy, but having a ready-made model, you don't need to have very high-tech GPUs or stuff, so you could test it out. Because, believe it or not, you as a radiologist have the best access for the data. Companies, scientists, they don't have it. They will approach you to get that data. The other thing, you will train it better than the companies. So you could tell, no, you have wrongly mislabeled this area instead of that area. So a quick shout for probably very nice platform. As Dr. Amna mentioned, having an AI platform is very important. There are even open source and free ones. Especially, I would see it a lot adapted many centers all over the world. Something called MONAI, MONAI. So once you deploy it, you could download different models, whether for musculoskeletal, neuro, and so forth. And from there, if you think it's your team is adopting it, you could go with vendors from that.
Any other questions?
Thank you very much. My name is Amir Bukhari. I have a question here about the legislations of using the AI in medicine, and in particular in radiology. I see Dr. Almosabihi smiling at my question, but I tried to do something about this, but I could not find any legislation governing the using of AI in medicine, not in Europe, not in the States, not in China. So I don't know whether is there anything here in Saudi Arabia, or is there anything going on to find something like this? Thank you very much.
Yes. Okay. So we can pass the question into the governance and ethics panel discussion at 2 p.m. Okay.
Thank you for that question. In fact,
It's very quick answers. I mean, we do have a legislations from the Saudi FDA, and in very short, we treat those as software as a medical device. So this is the short answer. It's been in FDA, it's been in European Commissions, it's also adapted here. So this is at interpretive sections. For non-interpretive, you don't need a license for that. For administrative, reminding appointments, you don't need for a license or regulations for that.
So by this question, I would like to close the panel, and thank you for the panelists, Dr. Abdulrhman, Dr. Metab, and Dr. Abdulaziz, and thank you.
Thank you for all.